This conference will now be recorded.
Good afternoon, everyone. The sixth day of our research methodology lecture series has arrived. I hope you enjoyed all the prior sessions. Today's session on the topic of single case design, case control studies, ethnographic studies, black box design, crossover design, factorial design, phases of clinical studies. This lecture is going to be presented by Dr. Renu Rathi ma'am. She has completed her BMS, MD in Cohort Study and done fellowship in health professional education. Ma'am also done a web course of bioethics, Haifa, and a SWAM course in fundamentals of clinical research by ICMR. At present, she is a professor in Department of Cohort Study in Mahatma Gandhi Ayurved College, Hospital and Research Center, Salod, Wardha. She has a total teaching experience of 21 years and PG teaching of 5 years. Ma'am posted as a head of department from 20 years. Ma'am presented 26 papers in national and international conferences. She was as organizing chairman in 8 seminar or workshop. Ma'am also acted as an organizing secretary in 5 CME or workshop. Her publications are 104 in international and national index prior reviewed. Ma'am published 31 papers in Scopus PubMed, 8 papers in Web of Science and 34 in others, and 10 papers are under publication. Ma'am completed 8 research projects with ISC by herself and 24 with scholars. Total 30 projects, research projects ma'am completed. Ma'am also completed one government collaboration MGIRI funded project. Her copyright are 4. She received 4 copyright, in which 11 are in pipeline. Ma'am also got National Best Teacher Award of ATA in 2020, Best Paper in National Conference, Best Essay and Video in National Competition on COVID-19. Her achievements are: she started Swan Prashar in Maharashtra in July 2010, appreciated by Lioness Club for Health Services through Ayurveda, and resource person in Ayush CME at Raipur on Cohort Study. Ma'am guided 6 PG students and 6 are in progress. Ma'am also a PhD supervisor since 2017. 5 scholars registered under her supervision. 1 scholar is awarded PhD degree. Now I would like to welcome Dr. Renu Rathi ma'am. Please come and start the session.
Thank you, Dr.
Welcome
Bhavana.
ma'am. Thank you.
Thank you, Dr. Bhavana, for nice introduction. Good afternoon to one and all dear participants. We will start with our new topic, different designs of clinical trial. Today we will see the types of study designs for small populations like single case design, case control study, crossover design, cohort study, as well as ethnographic studies and factorial design. We also clarify about black box design, which is a sort of new design, and also there is little bit dilemma of white and gray box design and their differences. So we start with the different study design types. We all know that there are two major study design types, like observational and experimental. Experimental design is mainly that design in which exposure or intervention can be manipulated by investigator. It means that in two groups we can rearrange or we can randomize the patients or blinding or making masking them and properly allocate them, and we can manipulate the intervention with the experimental group. But in observational group, there is no control over investigator. So exposure not manipulated by investigator. This is the major characteristic of observational design. So in this, investigator does not assign any exposure or intervention. Whatever, for example, in survey study, whatever facts or data collected with the help of survey, we can directly represent as it is. So we do not have to manipulate or any uh, analysis of that by investigator. Again, we can divide observational study into two major types, analytic and descriptive. Where there is no comparison, then it is called as descriptive design. We can take the two example of descriptive design is case series and cross-sectional. Also, ecological is a again third variety of descriptive design. Here in this descriptive design, there is a particularly in cross-sectional design, there is a exposure and outcome at the same time we have to assess. Whereas in analytic study design, the two examples are cohort and case control. And these two are exactly opposite with each other. In cohort means group of people. We can call it as the cohort. And in cohort, we need to check the exposure to outcome origin. Whatever cause or intervention is there, we need to go for the disease. For example, we will go forward with the clear-cut guideline of cohort in further slides. And other study design is case control. Here we can directly check out that there are two words, case and control. It means there is a comparison in between these two, case as well as control. And this is exactly opposite with cohort. Here we have the outcome and we need to check its exposure, that is cause or any intervention basis. So we will see one by one in detail. These are the traditional designs: parallel group design, crossover design, or factorial design, or add-on design, randomized withdrawal design, and early escape design. We will see first three in detail. These are other examples. Randomized RCT already we have discussed in last lecture. Then cross-sectional, case control, cohort, economic evaluations, and experimental studies. Other research designs are cluster randomized designs, matched pair designs, enriched designs, and special designs are N of 1 design, sequential design, decision analysis based design, ranking and selection design, adaptive design, and risk based allocation design. So the question comes, how can we check that which design is suitable for our case or our scenario? Then it all depends on the chronology of events, subject convenience, and trial cost. As per our type of study design or as per our type of research question, we need to choose the proper design to suit the our hypothesis or our research question. Classification as per design, we have already discussed that these are the classification, and accordingly our hypothesis or research question we need to check with the help of budget and all. Just I have discussed the factors dependent, and we need to choose the one. Now come to the hierarchy of level of evidences. We know that background information or Wikipedia has least importance in as a evidence. And as we go forward, that at the top of the pyramid, there is a systematic review and meta-analysis. Uh, and on the third top position, RCT is there. And we can consider it as a gold standard because meta-analysis and systematic review is based on number of RCTs only. We need to systematically review to the RCTs only, and we need to do the meta-analysis based upon RCTs only. So RCTs are gold standard, and we have already discussed about it. Today we will discuss about cohort, case controlled study design, and case report. So first of all, we will discuss on single case design. That is, it is based upon CARE guidelines. If we go through CARE checklist, you can directly by Equator Network. There is a checklist updated in 2013, and there is a clear-cut guideline what to do and which things should be incorporated in our design. It is a good one, and it is a good. It has advantage of being adaptable to the clinical needs of the patient and the therapeutic approach of the
This
for a
conference will
case
now
study
be
report,
recorded.
the patient in his or her own control. In case study report, the patient in his or her own control, and treatment can be randomized for a patient rather than the patient being randomized for a treatment. In last lecture of RCT, we have discussed that there are multiple patients and we need to randomize them, but this intervention is only single. But here the patient is single and we can randomize to different treatment. So this is the concept is totally opposite. Now, what is the design of a case control study? Now, the words, another design is case control design. Here, we can compare the case results with the control. Control it is another healthy patient and a healthy one, and we need to compare the results with the case. So, here is no randomization is required, and it is always retrospective. The objective of this case control design is to test association between exposure or any cause and the outcome of the disease, that is lung cancer. If we can talk about smoking as a cause and the outcome as a lung cancer. So here is the example of this exposed and unexposed with smoking, and we can compare that some patients are converted into lung cancer and some are not. So we already know the outcome of the disease, and then um, we are finding out the cause of the disease. So this is totally opposite with cohort. In cohort, we have already known factor is cause, and we are prospectively checking out with the disease or outcome. And here already we know about outcome and we are checking about cause or exposure. So here we need to calculate odds ratio, and accordingly we need to make the association between exposure and outcome. So case control study here in selection of case as per definition. Whatever case we are selecting, we need to specify it as definition. That so and so inclusion and exclusion criteria must be there, and as per the criteria, we need to mention the definition of the case, and then only we have to include such cases. Also, we need to ensure the diagnostic criteria also. If rare case, then we have to take only single case versus 4 patients of control, because the case is rare, so we won't get so many cases. So we need to compare with 4 controls with one single case. Otherwise, if cases are not rare, then we can compare with 1:1 ratio. Assessment criteria should be same for both groups to make comparison and find the association between disease and exposure. How should be the control? What is control? Control means the prerequisite of controls are control patient or control participant must be free from disease, and the other factors like all demographic data, age, sex, place, religion, etc. should be same to avoid confounding bias. If both are different, then we cannot properly conclude the bias or outcome bias. So, what is the presentation of data of case control study? As we know, the case and control when the study started. So,
initially everything we know about case and control. So addition of exposed and non-exposed together, thereby we can't calculate incidences. Incidences means new cases arrived, then it is called as incidences. And when we talk about old as well as new, then it is a prevalence. This is the difference between incidence and prevalence. Prevalence is including old and new cases, whereas incidence is only about new cases. As we could calculate the incidences in cohort study with the help of relative risk. So here the case is here is A and C. Sorry, here is A plus C is a total one. Here B plus D is total B plus D. And when we make total of horizontally A plus B and C plus adding with A plus B plus C total, that's why we couldn't calculate the incidences. Interpreting the odds ratio. Odds ratio, if it is equal to 1, then we can interpret that cases and controls are same. Exposure is not associated with the disease. This is the inference that exposure is not at all related with or associated with the disease. If OR, that is odds ratio, is more than 1, then we can conclude that exposure is positively associated with the disease, because here the cases are higher than the control. And when the odds ratio is less than 1, then cases are lower than controls, and we can conclude that exposure is negatively associated with the disease. What about cohort study? Cohort means the group of people, and suppose one locality or one ward or one whole area should be compared with another whole area. So it is a cohort, and the characteristics of two cohorts must be same. So if we know that certain locality has hypertension in that prevalent in that area, so we can find out the outcome of the disease, that how many of them got IHD, that is ischemic heart disease or heart attacks. So the exposure is known, and we need to find out the outcome of the disease, outcome or disease. So if certain thing is exposed, population is exposed, we out of the whole population we can divide it into two groups. Some people are exposed, some one cohort is exposed and another is non-exposed, and we need to compare between them, that how many of them remain non-diseased and how many of them develop disease. So we need to find out the incidences, and on the basis of relative risk we have to calculate the things that which group is more prone to develop the disease. The type of cohort studies are three: prospective, antispective, as well as retrospective. If we start the study from A point and there is a exposure as a cause, and later we have to find out the just now I have given example of hypertension and getting the disease as a IHD. So this is prospective study, because in future we have to find out the disease relation. Here exposure and study starts all together, and exposure is starting. We know the exposure and the study started, and disease is also getting the in between, and antispectively we in the both way we can find out the association between exposure and disease. In retrospective, the study starts at the end, and the disease and exposure relation we have to find out. The disease is already known, and then we have to find out the exposure. What are the elements of cohort study? These are four, mainly based on selection of population, because cohort must be as a subset, and we need to choose them as a proper with all essential characteristics of similar characteristics of two cohort, that age, sex, prakriti, viable, kal, like that. Gathering baseline information is the second element for the cohort study, that is assessment of exposure of cohort. That cohort, particular cohort, must be get exposed with the same reason or same cause, then we need to follow up them, and at certain period of time we need to analysis them and make the conclusion. The next study design is matched pair parallel design. Here we can see that these two are matched with the similar characteristics, and as a parallel one at a time 4, we can compare the results, and we can find out that which pair is more giving more outcome, or outcome we can find out. So the advantages of this study is that it requires small study population. Whenever the population is less and small, we can we can design this type of study. It can reduce variability from treatment comparison, because compared with parallel group design, we can in short period of time we come to know that which pair is more suitable for that intervention or not. Disadvantages are the prognostic characteristics are not easily defined, because we need to make them match pair. If the characteristics are not matching, then we need to check, we need to select properly, and the patient recruitment is getting slow, because we need to every time this is the essential criteria that we need to pair them, and then only we can parallelly compare them. So here, if the covariates means if the similar variables are large, then the design is difficult to implement. If age variable, Kal, Prakriti, if there are so many variables and we are matching everything about the next pair, then it is very difficult to find the same similarity in all population and then choose them and then start the design and find out the conclusion. That's why in this, whenever there is a multiple variables, the recruitment is slow. But in small sample size, we can make it the same. Another design is crossover design. The word itself suggesting that it is a crossover, means more than one treatment at different dosing periods are essential prerequisite for this design. A block can be patient or a group of patients, and the patients in each block receive different sequences of treatments. A crossover design is called as a complete crossover design if each sequence contains all treatment under the same setup. So for this beautifully depicted flow chart, we can come to the conclusion that this is the population, and here we have to randomize into two groups, that is group A and group B, and then suppose for example for group A, here I am giving say Tribhuvankirti to group A and Mrityunjay to group B, then for 15 days, and after 15 days for 15 days period of time, or 20, or say 1 month time, where I have to I do not have to give any intervention, means there is a nil period. Washout period means there is no intervention should be given, and after that washout period I need to give this Mrityunjay to the same group of people in which I have earlier given Tribhuvankirti. So after a period of time, lapse of period of time, then only I have to give second intervention. Here, first of all, I have to give Mrityunjay, and after a washout period, say 15 days or 20 days, and later in which washout period there is no intervention, and later I have to give this Tribhuvankirti. So this is a crossover. Here Mrityunjay and Tribhuvankirti, and here Tribhuvankirti to Mrityunjay. Here is a crossover fashion. I have to repeat the cross in a crisscross fashion. I have to change the intervention with a washout period and make the inference that which drug is more suitable, more giving result to the group of people. So in small group of study, it is a very good unique one, and particularly objective methods and interpretable data for both relates with the efficacy and safety, because we in short period of time we come to know that which drug is more safe if ADR is developing or any rash or any side effects are originating, then I have to stop the drug, or we can come to know that which drug is more allergy prone or not suitable. Then this type of study is mainly suitable to chronic or relatively stable diseases. Prophylactic drugs means whatever the preventive modality, preventive actioning drugs are more suitable and with relatively short half-life are being investigated. Relatively short treatment period are considered, say 8 days or 15 days at max. And later, after washout period, we need to give another intervention and need to check which one is better. So baseline and washout periods are feasible to the practitioner or researcher. What are the advantages and disadvantages of this study? The advantages are it allows a within patient comparison because the group of patients are same. The only thing is the difference of two interventions at the since each patient serves as his or her own control, and we need to remove the interpatient variability from the comparison between the treatment. So the group of people, two interventions are we can find out which one is better. With a proper randomization of patients to the treatment sequence, it provides the best unbiased estimates for the differences between the treatments. And the advantages are, it may happen that there is a carryover effect, the residual influence of treatment on subsequent treatment periods and avoided by washout period. So it requires it acts as a disadvantage that order effects, order in which the treatment are administered affects the outcome. Suppose if Twinterus is more good and I am giving initially starting with Tribhuvan, then it is an order effect that this is the disadvantages, because group B, suppose I am saying that group B will start with Mrityunjay only and group A with Tribhuvan only, then this is the order and I could not change this order because there is again crossover fashion already will happen in future. So this is the order effect and period effect. The difference between the study period is because we need to keep the washout period also to discard the carryover effect. Another study design is factorial design. Factor means factorial. Factors are so many factors are together, means the word itself suggests that number of factors on the treatments compared with the similar different short population, their interaction, their safety, efficacy with different treatment. Suppose to group A I am giving Tribhuvan and group B to Mrityunjay, and in third group of people A plus B means both interventions are together, Mrityunjay as well as Tribhuvan, and to another group of people no intervention is allowed. Then I have to check the different factors, which one is more suitable, which one is more giving reliable results, whether group A or group B or group A plus B combination is working or no at all, no intervention is working. So on the factorial basis we come to the inference that which one is acting better. So this is factorial design. What are the advantages and disadvantages, and when to use such type of design? Useful for clinicals, two treatments, same number of individuals. Influence of a number of factors can be studied together, which might require many trials if done individually, and establish dose response characteristics of the combination of A and B when efficacy of each has been previously established. So we can minutely we can make the inferences about the factors. Advantages are a greater precision may be obtained in estimating the overall main factor. Whether it is producing the third product or third any complication or third any ADR like that. So interaction between different factors can be explored. Then additional factors can help to extend validity of conclusion derived. And disadvantages are difficult to analyze because the interventions are continuously changing. So it is difficult to analyze. Large designs require large number of subjects. And between subjects there is a design lacks statistically because the variables are continuously changing, and there is a little bit selection of the statistical test is difficult. Then we come to the ethnographic. Ethnographic, the word says that it is a historical or that documents the social and cultural context in which traditional practice and behavioral change emanates where there is no available scientific literature or other documentation. For example, our science is an ancient one, and we know that since ages folklore medicine is available. They are medicine. Hypothesis may be generated and can lead to further research. Now we will go about the details of ethnographic studies. Ethnographic research is a multidimensional research design that can be adapted to different fields including business, medicine, education and psychology. Based on different fields, it has specific characteristics, identify needs of student or market or consumer, and satisfy the demands. And this method combines different techniques to collect and analyze the data. Beneficial research tool to come up with the conclusive strategies. For example, business, medicine, or psychology or medical field, we can conduct this such type of studies, and it involves observing teaching and learning methods. If we talk about educational ethnographic research, then it facilitates the attention about pedagogy, or what are the learning outcomes or overall engagement by stakeholders within the classroom environment, and it finds out the students' attitudes or interest towards the learning or academic motivation, then disposition to learning, and we can take feedback after the lecture or after the teaching about the satisfaction, about the enjoyment, or about their inclination or attitude towards the learning. So it provides the instant feedback, and it facilitates the chance to update ourselves. If we talk about medical ethnographic research, just we have discussed that folklore medicine is in practice since ages, and it used for qualitative investigations in healthcare to understand the disposition of patients ranging from the simplest to the most complex behavioral patterns. It enables the access of information to improve patients' overall experience. To understand the needs of the target market and in turn influence the product design. Which intervention is better, or which investigation is more suitable in that particular disease perspective, like that. So it gives insights, quick insights to the based of setup based or intervention based inputs. And it also facilitates the feedback that how you use this drug, and how long have you been on this treatment, and whether you have noticed any side effects or positive changes, or how quickly you got the results, like that. So satisfaction, their concerns, their side effects, their any type of feedback we can take quickly, and accordingly we can mold the design and change our intervention and setup. The last is black box design. We directly we can know that the black box, we can't see in the black box what is there in the what is there inside. This means that the treatment and all of its components are delivered as they would be in the usual clinical situations, and if there is no component of the treatment, the package is isolated and studies independently. Means the if we don't know anything about the drug, for example, say any new drug which is not for elaborately discussed in our Bhratrai or in our Sanhitas and all, then if such drug, new drug, if any herb, हिमालय के पास का कोई ड्रग है जो if we don't know रस गुण विपाक प्रभाव and action karma of that drug, and to such not knowing anything of that drug is called as black box, because we don't know anything about that disease. So black box contains the whole system research, that our Ayurveda, multiple interventions at the same time. We are giving procedure also, we are giving multiple shamanoshadis also at the same time. So which intervention have worked properly, we do not come to know. So this is black box design. Ultimately, all things are all together, and which thing is mainly focusing or giving results, we cannot directly comment. We can't comment. So Ayurveda can make better use of this design, because action of herbal drug from rasa to prabhav, rasa guna vipak prabhav, there are that one single drug do its action on the variety of aspects. So we need particularly the action only, how it works and on which basis it has worked. We have less interest on that particular topic, but we as research point of view, we must know which part is more focusing, then only we can develop our science. So this type of design is beneficial if we find out and do certain research, because until and unless we don't do practice on such things, we can't comment and we can't update our science. So there are various techniques to typically drive the black box test. That is decision table testing, all pairs testing, equivalence partitioning, boundary value analysis. The most important is boundary value analysis. Cause and effect graph is also useful, and error guessing. Error guessing means we are if we are giving certain intervention, certain treatment to that disease, and if it is not work, then we can call it as a error guessing, and we have to change the drug, then it is a error guessing, that this type of intervention is not working, then we need to check the another one. The व्याधि उपशमनार्थम एंड व्याधि विपरीतार्थम, जब हम जो चीज हमें अगेंस्ट लगती है, मतलब उसके विरुद्ध हम उसकी ट्रीटमेंट देते हैं, लेकिन अगर वो वर्क नहीं कर रही है तो हमको वी नीड टू चेंज द इंटरवेंशन. Now there are dilemma of black box, white box, gray box. What it exactly means, and what are the differences in between these boxes? These are the different things that we come to know that in science, different things. A black box is a system which can be viewed in terms of its inputs and outputs. Means without any knowledge of its internal working, it is a black box where we don't know anything about the internal working, how it works. It is a black box. And fault injection is not a black box testing, means it is implementation as a opaque exercise a system and end to end. Means particularly if we don't know anything detailed, then it is a black box in the simple words. And it focuses on determining the boundaries for input values and testing at those chosen boundaries. Means suppose one herbal drug is there, so boundaries are how it acts, rasa by rasa guna virya vipak prabhav karma. These are the boundaries of that drug, and we need to check with which testing or which by which method, by rasa it is acting, or by virya it is acting, or by prabhav it is acting. So we need to find out the boundaries and the internal working of the drug. This is the difference between black box, grey box and white box. White box means everything we know, the full knowledge we have about the drug. Suppose any botanist is there, or Dravigun person is there, so he or she must be knowing about that typical drug which we were discussing bit before, then it is a white box for them because they know everything about that drug. And grey box means suppose students some have a little bit knowledge or limited knowledge about that drug, and not exactly, no full knowledge is there but limited knowledge is there, so कुछ पता है और कुछ नहीं पता है, that is called as grey box design. And black box means if the internal workings at all we don't know, then it is a black box. It is also known as closed box or data driven testing or functional testing. Grey box is known as translucent testing because somewhat we can say, so we can watch, we can see, we can visualize, but clearly not. So it is a translucent method. Little bit half knowledge is there, and it is here. It is a clear box. The white box can be synonymically changed, clearly depicted as a clear box, where structural testing or code-based testing or internal working is clear-cut described or known. Then in black box, it can be performed by end users and also by testers and developers who have that developed that drug or that some machine or any equipment. Then it is who have developed it, or the scientist or that engineer, or who can better talk about that things or explore the thing from the unknown. They have to work upon it and make it known. For grey box, performed by end users and also by testers and developers, and here normally done by testers and developers. Testing is based on external expectations and internal behavior of the application is unknown, because here nothing is known, everything is unknown. So the testing is reliable and the expertise is required because we need to explore the things. Here testing is done on the basis of high-level database diagrams and data flow diagrams to depict the internal design or how it may work. There is some database or diagrams or data flow diagrams to explain the need to know the workings. And internal workings are fully known and the tester can design test data accordingly. So in short, there is just only clear thinking that black box is unexplored one, the grey box is like half knowledge, somewhat is known and something is not known, and white box is everything is known, clear knowledge is there, and we can divide it into three. Now come to the observational design. Observational studies collect findings on a therapeutic or prophylactic treatment under routine conditions. The special feature of this study is that they seek as far as possible not to influence the individual doctor-patient relationship with respect to indications and the selection of and carrying out the treatment. These studies may be conducted with or without a control group, because it is not necessary that they, like survey, for example, survey study don't have any control group, any comparison. That's why it is observational design. It has specific advantages in studying aspects of clinical safety. How is it safe or no or not? We can come to know by asking questionnaire or and directly after getting the data, we can plan the study to test the hypothesis. Until and unless we don't know about the safety, efficacy of that particular drug, we can't plan the further research as an experimental one. So observational design make a good platform to plan the further research on basis of exploratory or experimental. There are certain guidelines, as we have discussed about RCT, that consort is a good one for the to check the guideline. As a guideline, consort is based for RCT. So here STARD guideline is based for diagnostic or prognostic study. There are different 475 guidelines at Equator Network, and also animal preclinical studies. ARRIVE guideline is there, which is based, which is for animal preclinical studies. For systematic review and meta-analysis, there are three major guidelines. First and foremost important is PRISMA, and another is Quorum, and third one is MOOS. MOOS is only based on some observational studies. So MOOS is different than PRISMA. PRISMA is for all clinical designs, clinical studies, design or RCTs, and MOOS for observational systematic review and meta-analysis. Why research in Ayurveda is needed? Because every science must to be updated, and that's why to globalize it or to popularize it, we need to do research in Ayurveda also, because many have concern that Ayurveda don't require research, but it is not the thing. If we have to establish our Ayurveda globally, then we need to do research in Ayurveda also. So industrialization and for health tourism, Ayurveda is a very good to popularize it from home to home, and from every village or districts or state level, and all over the country as well as internationally. It increasing demand as a evidence based, because until and unless we don't do research, then we cannot put forward the evidences, and then only we can establish the facts with the help of evidences, and uh, uh, prefer our things more efficiently. Then drug standardization. There are so many drugs, and they need to assure the quality as well as quality assurance and quality standardization. So it is a part of research. So we need to do it. Then to develop new drugs and formulations, because so many good formulations are there, and we only know about whatever is available today with the help of our Sahitas and our good books only. But what is unknown, which so many books are we missed in Nalanda and Takshashila, and but so we can explore them with the help of folklore medicine, and we need to re-establish them. So classical formulations losing ground, we need to re-establish them as a reverse pharmacology, and to develop new indications or new formulations and new dosage formats. Need to explain fundamental principles as a Maulik Siddhant Vibhag, and to publicize safe, cheap, and quickly effective interventions to stay healthy and happy. At the conclusion, we need to prove our concept to precede clinical trial, because clinical trials are having top of the pyramid, and we need to re-establish certain facts that how good Ayurveda is and how safe Ayurveda is. So for any research, the design must be robust, because if the design is proper and we plan it properly, then only our research will come out as a good one. Otherwise, it will get failed. So, well-designed protocols with Ayurvedic concepts, because we should not forget to add Ayurvedic concepts like Vayabal, Kalru, Prakriti, and all Agni. And these Ayurveda concepts are very much important. Not we should not talk about only drug or new drug or only intervention or only diagnostic tool, but we should add Ayurvedic concepts too. To combinedly, we can prove that our science is how good. Objective to evaluate treatment regimen including the trial. So objectives must be clearly matched at the end of the study. And assessment of quality of lifestyle and disease parameters we can assess with the help of research, and research conduction as per different guidelines. Now we have discussed all different study designs and which guideline is most suitable, and with the help of these guidelines only the research must be conducted, and such conducted research must be published to the highly indexed journals like peer-reviewed journals, Q1 to Q4, Scopus or PubMed or Web of Science journals. Then only we can strongly comment on we can foremost and bring our globalize our Ayurveda. We must stick to our certain guidelines like GMP, good manufacturing practice, or good animal agriculture practices, or cultivation of drugs, or good clinical practices, and SOPs of the trial drugs, and quality of the products that many times there is a adulteration, or there is a the drug is not matching with quality assurance and quality safety, and so we need to stick on consistent quality of products and sincere efforts to improve the quality of clinical trials too, because clinical trials require so much patience and dedication. We have in last lecture we have discussed that there is a 4D that must be strictly we need to do the research on the basis of determination is there, discipline is there, and dedication is there, like that. So there are many problems coming towards clinical trials whenever we conduct research, but we should make a way and forward further. Then only we should not keep calm and give up, but we should forward the our research on the basis of guidelines only, and we must add our Ayurveda concepts too. So thank you all for patient listening, and I will be happy if any queries I can answer. Thank you all.
It was really a very nice presentation, ma'am. Thank you. Now it's time for question answer. I invited to all participants. Please, you can ask your doubts one by one.
Is there any questions? I could not see here in chat box.
Yes, ma'am, there is a question. Please explain black box, gray box, and white box design with example.
Yeah, I have already given examples if you heard properly in the deliberations that if we don't know anything about a particular drug or formulation, then it is a black box. That's why we have to start from A to Z, from clinical animal experiment. We have to start it. If we find it efficiently effective, then only, and effective as well as safe, then only we have to go forward with the case control, and from phase 1 to phase 4 trials, and then we have to launch the drug. So if we don't know anything about that particular formulation or single drug, then it is a black box. And if we all know about that drug, is a white box. And if we little bit having half knowledge, then it is a gray box.
Okay, thank you, ma'am. Anyone having any question? Okay, ma'am. Now we conclude the session. Vote of thanks. Please wait, ma'am. Myself, Dr. Bhavna Bhardwaj, PG Scholar, Panchakarma Department of Ayurveda and Unani Tibia College and Hospital. I would like to thank our guest speaker, Dr. Renu Rathi, ma'am, for enlightening us with their knowledge. Today's webinar was full of knowledge about the study designs like black box design, crossover design, etc. It provides some interesting points. And lastly, thanks to all participants from the behalf of Panchakarma department for patiently listening this webinar. Tomorrow will be the webinar will be started tomorrow at the same time from 2 to 3:30 p.m. Thank you everyone. Thank you so much, ma'am. Thank you.
Thank you.